I'm trying to remember. There was a time, I think it was 2005, and I was struggling to do the math, and I can't believe it's 18 years ago now. I was in Northwest Texas. I was in a hospital that I was running as a turnaround. And there was a little couple. They were, I'm guessing, late 70s, early 80s. And they were talking about how they loved their hospital. And I said, well, where are y'all from? Oh, about 100 miles west of here. And again, this was Northwest Texas near the Panhandle. And I said, you drove 100 miles to get here. It was the closest option. That is not uncommon for rural Texas. It's not uncommon for people to be able to find a doctor to get the care that they need. We're spoiled in the cities. You know, we can throw a rock and hit some kind of building that has a hospital or a doctor's name on it, or has some kind of medical professional that will offer you care. Just not the case for many parts of this state. And in fact, you know, as we were looking at research, did you know that there are 42 states, or 42 counties in our state that don't have a single doctor? That's a remarkable statistic. Our rural communities and the rural components of this state really have incredible challenges. There's out-migration coming out of smaller communities into the suburbs and into the cities, or out of state. We have a dire shortage of physicians and nurses. We're having medical facilities that are closing, and that's being brought up many times over by various people for various reasons. We have a multifactorial set of problems, and I can assure you that there is no single solution that's going to address those problems. So what's it going to take? It's going to take solutions that address the root cause issues. I'm very proud to be on this stage because we've been with some folks that want to be a part of the solutions and have. In this last session, in the last legislative session, we saw Speaker Phelan start an initiative called the Healthy Families, Healthy Texas Initiative. Dr. Oliverson was a big part of that with many bills that have deep impact into rural Texas. And I don't want to get this wrong, so I need to break out my piece of paper to do the introduction. But that package had a number of bills, and it made waves across the nation. And we're wanting to look today, we're going to look at how that's made an impact, and then look to this session to see what are we going to do this time around. So I'm incredibly honored to sit on this stage with the folks here to my left. Let me start with the Honorable Tom Oliverson, Dr. Oliverson. Represents Texas' 130th State House District in Northwest Harris County. In his professional career, Dr. Oliverson is a board-certified anesthesiologist. Don't hold that against him. I'm just saying that for the benefit of the anesthesiologists in the audience. And partner at U.S. Anesthesia Partners, the largest group in Texas. Was selected by Speaker Phelan to chair the Committee on House Insurance and also serves on the Public Health and House Administration Committees. Additionally, Dr. Oliverson was selected to be the vice chair of the House Republican Caucus. He has authored legislation on a diverse set of issues, including healthcare, education, local government, religious freedom, the Second Amendment, and protecting the unborn. To his right is Jarrett Hill. Jarrett, thank you for being here. You're pinch hitting for Cy Cook. Cy Cook couldn't make it. He's ill today. If you're watching, we wish you well and a speedy recovery. Cy's Executive Director and Chief Operating Officer of the Farm Bureau. And Jarrett, I'm sure you're going to do a better job, to be quite honest. Just a joke. Government Relations Manager at the Texas Farm Bureau Insurance Companies. Jarrett joined in 2020 after spending 4 years working for Senator Kelly Hancock. Prior to that, he worked for Governor Abbott and worked in the governor's office at the office of the...
And when he was AG.
And when he was AG. He wrote very small, and I don't have my glasses on. Grew up in Carthage, Texas, and graduated from UT Tyler, UT School of Law. And I can't read the rest of that, so I'm going to shut my binder. Guys, thank you for being here. I really do appreciate it.
My pleasure. Thank you.
Dr. Oliverson, let's get into the many successes that came out of last session. Tell us about what happened and what has been the outcome to date.
Yeah, so good question. So, ever since I got here, there's sort of a small group of people like yourself, and I see Charles out there in the audience, and there's a few others, and we've known for a long time that if you really want to reform healthcare, you got to put it in the hands of conservatives, because the biggest thing driving the explosion of cost is actually sort of what I would call the governmentalization of healthcare. We got to get consumerism involved, and we need this segment of the market to function like every other segment of the market. So this is sort of an idea. I've been working on this, all this kind of, I've got this stuff we're working on. We've done some really cool things. Senator Hancock and I passed legislation in 2019 addressing a very thorny issue, surprise medical billing. And David, you worked on that with us, and that ended up becoming basically the national blueprint for the No Surprises Act, which had it been implemented in a way that was a Republican implementation as opposed to a bad Democrat implementation, it probably would be working properly. But right now it's more like a dumpster fire burning out of control. But that being said, so fast forward to this last session, we were very, very blessed in Texas to elect a conservative Speaker of the House who basically kind of pulled me and a couple of the other chairmen and chairwomen into a meeting and just said, look, conservatives can win on health care. Conservatives have all the right ideas on health care. Democrats only have one idea, and that's more government. And more government does not solve the problem of health care when the problem is price, affordability. And it was like, we were all just like, whoa, wait, who told you to say that, right? Because that's literally what we say all the time is, coverage doesn't equal care, right? And so he said, I want you to put together a package of bills. And there were 4 of us sitting around the table, and he said, you're my team. I want you to put together a package of bills. And so we did. And we went out and we found really good policies, I think. And the end result of that, as you know, was that former Louisiana Governor Bobby Jindal noted after the session was over in his editorial to the Wall Street Journal that Texas now leads the nation on conservative policy solutions for health care. And I will tell you, ladies and gentlemen, what it takes is a leader that basically says healthcare is a priority to many Texans. Conservatives actually have all these good ideas on healthcare, and it's time for us to take that issue back over and not leave it to the other side and their big government solutions. So, yeah.
No, I agree, and unfortunately, at the federal level, many people on that are Republican or on the conservative side are told, don't talk about healthcare. And our position here in this state is we lean into it. It must be discussed. We have to talk about the impact that the lack of affordability and the lack of access have on our communities. So these are some of the things. So as part of that package, Dr. Oliverson, what were some of the ones that you authored and that you saw through, and maybe some others that you didn't author that you really liked?
Yeah, so the ones that I think we'll probably spend some time talking about today, that the one that I think moves the needle on affordability, but there's 2 really. One of them is that Senator Kolkhorst and I worked together on a legislative initiative that basically took a part of President Donald Trump's price transparency rule and codified it into law. We all know that if people can't know what the cost's going to be before they purchase the service, there's no way to control costs. I mean, there's a reason why we're not all driving Lamborghinis, right? And it's not because it's a cool car that comes in some pretty unique colors and it goes real fast. It's because it's so unaffordable, it's not a good economic value for us. So that's the biggest problem in healthcare, is that people can't see the price up front. Imagine going to buy a car and having somebody tell you that you have to drive it for 30 days before you get to find out how much you have to pay for it. That's insanity. But that's how every sector of healthcare works, with one exception, David, and you know what that is cosmetic surgery, because insurance don't pay for that. So consumers want to know what the price is up front, and surgeons want to know, if you're not the surgeon, what do you charge for anesthesia? What's the facility fee? Because I've got to run a competitively priced business. So that was big. But the other one that I think was truly big is that under the ACA, there were two big exemptions. One had to do with health sharing. The other one had to do with a benefit plan offered by a state Farm Bureau insurance company. And there were a handful of states that did this. Now, the thing that makes this unique is that a Farm Bureau is essentially a member-owned, almost like cooperative company where the profits go back to the members, the board of directors are elected by the members. So the company is under the direction of the people who are actually seeking the benefits and services that the company is providing. It's a very unique model. And the government at the federal level wisely recognized that this organization could offer health benefits in a relatively unregulated environment because of its unique tie to its members, that essentially, because they were all shareholders and voters and had control of the company, if it wasn't something they wanted, they were going to vote those people out and replace them, right? So what we saw in places like Tennessee, where Farm Bureau had been in business doing health coverage for 50 years, was tremendous savings. Like, we're talking like more than 50% savings over what a silver or a gold plan might be on the exchange if you didn't have access to a rebate or a subsidy. And so we said, you know what, we want to do that in Texas. And I'm proud to say that our Farm Bureau in Texas is an amazing group of people, visionary people. Cy Cook, who couldn't be here today, was just an absolute visionary on this. I mean, as soon as I explained to him what we wanted to do, he's like, Dr. Oliverson, I think we want to do that. I got to go back and talk to my board, but we absolutely think that that would be a valuable benefit to our members. So those were two of the really, really big things that we did. There were obviously a lot of others. We allowed Texas Mutual, which is our largest workers' comp carrier. Chairman Frank had a bill that basically kind of did the same thing, but with Texas Mutual. We had a prescription drug benefit program to get low-cost prescription drugs available. We could talk about Medicaid if you want, but I don't know if we want.
We can come back to it.
We'll come back to it. So that's we'll come back to that. Anyway, so a lot of good stuff. And we literally got everything across the finish line except for one little bill of mine and Chairman Hancock's. And so we're going to get it done this session. It's going to be our first bill that we pass probably.
Well, I think that's a great segue to talk about the Farm Bureau. And we wanted to have you all here because of the visionary leadership of your organization to jump in and say, yes, we want to participate. We would like to see a bill like this go through the process, and it did, and it passed and was signed into law. And you all didn't really let a lot of grass grow under your feet. But before we talk about what has happened, why don't you tell folks what the Farm Bureau is? Because many people may not understand or think, well, it really doesn't apply to me because I'm not a farmer.
Sure, David, I'd be happy to. So what is the Texas Farm Bureau? So there's farm bureaus in every state, and if you've met one farm bureau, then you've met one farm bureau. But we all are the voice of the agriculture industry in our state. Texas, obviously going back to when we were first settled, heavy agriculture presence here. Texas has grown and become more urbanized over the last century, but agriculture is still as important, if not more important, today as it was then. So, why would you join Texas Farm Bureau? Well, when you sign up, you sign a pledge card saying that I support the welfare and benefits of agriculture and the rural way of life. And so you've got the agricultural component, you've got the rural component, and sometimes those are mutually exclusive, and then sometimes as you might have seen in the House Ag Committee today, one of the bills that they were talking about was private property rights as they relate to ag operations in neighborhoods, having things like chickens in your backyard. So as we've learned the last 2 years, 3 years, I've lost track of time because of COVID, but all the supply chain issues and everything, the amount of work it takes just to get something from the crop or the pens to the grocery store it's incredible, and we shouldn't take that for granted. And so Texas Farm Bureau, what do they advocate for? Well, ag policy, safe ag policy, abundant food supply, choice in food supply, private property rights that should be protected at all costs, responsible government, and responsive government. How is the Farm Bureau, how do they ensure that mission is successful? Well, you've got SI as well as the elected members at the top. We've got a 14-person board. They are all elected, but you've also got 204 county boards across the state, and that's where the grassroots starts. That's where the policy gets done, and I feel confident saying that every policy that is advocated for by Texas Farm Bureau in the Texas Capitol starts at the grassroots level, and that's who holds us accountable.
So how did you? How are we here talking about health insurance?
Well,
First of all, we don't call it health insurance,
How do
but
we talk about health coverage?
yeah. So it's it's kind of a long journey. So I won't spend too much time, but I'll kind of tell you where we were. So among the things Texas Farm Bureau does is we offer member services, and something we have done in the past is we have offered health insurance. Now, as consolidation took place in that market, more regulations were passed, and you saw everything move to this one-size-fits-few approach. Health insurance just became more and more unaffordable, and ultimately with the passage of the ACA, it became a level of unaffordability that we just weren't comfortable offering. And so, we stopped offering it, but the needs of our members in the rural and ag communities never changed. And it's something we hear about. We know we have members who have a spouse that may have to work outside the family operation, get a job in town just so that they can have health insurance. That takes them away from a valuable family operation that they may want to participate in. There may be a lack of access, which I know we'll talk about today, or affordability. And so, where we were 2 years ago at this time was we were meeting with Dr. Oliverson, and because of his commitment to this idea, as well as the proven track record of Farm Bureau health plans in other states, and that's something else I want to emphasize. It's new to Texas, but it's not an experimental project. It's got a proven track record of decades of experience. So we, between his commitment, the proven track record, and the support of our organization, it's something we lined up behind. We got it done. And I think because of your commitment, as well as the statewide presence and reputation of our organization, it passed with bipartisan support. And so that's where we are today. And something we appreciate working with Dr. Oliverson about is for a lot of these problems, especially in the healthcare space, the way it's always been done just isn't working. You've got to throw out the playbook. Not everybody wants to do that. And so whether it's Farm Bureau health plans, MEWAs, Texas Mutual, or the legislation you and Senator Hancock authored back in 2019 on balanced billing protections, you've got to be willing to throw out the playbook sometimes and sometimes drag stakeholders to the table to work out the issue.
Well, speaking of throwing out the playbook, you all have changed the playbook when it comes to benefits. Can you talk about what impact has this new development, this new law? What kind of impact has it had on rural Texas?
Well, so we launched it late last year in August. It was our statewide rollout, and so we wanted to do a slow, methodical rollout, make sure we checked all the boxes, and we didn't repeat any mistakes of other health plan launches that we've seen the last 10 years or so. So right now I think we're right around between 2,400 and 2,500 lives covered. We offer several products to meet the consumer's need. We don't just have one product. We have your traditional PPO plans with deductibles ranging from $1,500 to $6,000, so you've got some choice on deductibles.
It's been a long time since I've seen a $1,500 deductible.
Yeah. We've got major medical, and we've got high deductible, which is, depending on how you do those, you can use a HSA and get some tax savings. And we also have a standalone dental and vision. We're very proud of the coverages that are in there. If we put something out there that our members didn't like, we would know that pretty quickly, and so we wanted to make sure that we did our due diligence, and what we put out there was something not only that would they be comfortable with, but would we be comfortable with if that was our option.
Well, and I'm been pleased to hear from your leadership that many of your new members are folks that were previously uninsured. So that was one of the aims. That was one of the goals. So appreciate you being here. Appreciate the work that the organization has done.
Of course. Thank you for having me.
Dr. Oliverson, let's talk about what else are we going to do? Looking at this session, so there's a buzz when it comes to healthcare. People are looking. Well, we did have a great prior session. It was talked about in the Wall Street Journal. Other states are pointing to what has been accomplished and achieved in the state of Texas. Do we have any designs on doing that again?
Well, of course. So let me begin by saying that that the Farm Bureau has, I need to say this so you guys understand that one of the best things about working with them is sort of they understand the importance of getting this right the first time. This has not been a reckless, careless, throw something against the wall and see if it works kind of layout, which is typically how things go in healthcare, and then the legislature has to step in and say, no, that's not what we asked you to do. Farm Bureau has done the exact opposite. They've been very careful, methodical, and as Jarrett alluded to, when you think about healthcare inequities in rural Texas, I think there's really two main buckets that you're dealing with. One is that we're going to talk in just a second about provider shortages and people being able to access a care provider. But the other piece of that is that there's a lack of competition in terms of people being able to get access to health care at a price they can afford. It's not just about providers. There are a lot of counties in Texas, rural counties, where you may have one insurance plan offering or none. And the vast majority of people are either uninsured or on Medicaid. And so what Farm Bureau does is it jumps into these situations and it actually offers a better, more affordable way for people to finance the health care that they need access to at a price that's more affordable and, quite frankly, inject some much-needed competition into the marketplace in some of these jurisdictions where, it's been one of the big insurance carriers literally for 30 years and no one else. And they sort of rule the roost, and it's whatever price they want you to pay, and if you don't like that, you're uninsured. So we needed that. We really needed that, and I just want to say thanks for doing that. But I think one of the big things that we heard actually sort of started coming up during the special session has to do with workforce shortages in healthcare. This is an unfortunate consequence and side effect of the pandemic, combined with the fact that we had an aging workforce in healthcare anyway, and we had pre-existing shortages anyway. And then through a combination of just very high pressure cooker, stressful situations, what I would consider to be some really stupid both government and corporate policies regarding what you had to do in order to keep your job working in a healthcare environment, and just a variety of other circumstances, we have significantly depleted our healthcare workforce. And the problem there, as we heard during the special session, is that it's rural places that suffer the most. It's rural communities where you may have a family practice doctor, I see one sitting in the audience here, who basically is the only person available to deliver a baby within 100 miles any given direction. And the hospital where he practices at now only has a labor and delivery nurse available 2 days per week. And so the rest of the time, and that's because those nurses that were working there, now because of the snowball effect, they have up and left and sought more lucrative opportunities in the big city because there are shortages there. And so it just sort of rolls downhill, as we say in Texas, and The problem is that it's our rural communities right now that are suffering most acutely from a lack of providers. And by providers, I don't just mean doctors. There are places where we have plenty of doctors, but we don't have nurses. And quite frankly, nurses are the ones that keep the hospitals running. The doctors just show up and order tests and see the patient and do their stuff. But if it's not for our nurses, that care is not actually being delivered in the inpatient setting or the outpatient setting. And so we need more nurses. And that's an acute thing. We heard that loud and clear from the rural health community during the interim. And so that's something that we're aggressively working on. There's a package of bills I think you'll see in Healthy Families, Healthy Texas, but let me just talk about two broad approaches. Chairwoman Click is working on a piece of legislation in an area that would actually create a better pipeline and more financial support for broadening and expediting the training of nurses, because that is a clear shortage area that we have. And so to get more people in the field, it frustrates me that I believe every year there are people in Texas who want to be a nurse, but there's not a training program available for them, or they can't afford it. And I'm sorry, but this is an all-hands-on-deck, 5-alarm fire right now. And we have got to get nurses out in the communities in any way possible. So that's a strategy. Another strategy is basically we want to make sure that we actually are getting every type of person with advanced medical training that could have a role in healthcare off the bench and out into the game, right? So we can train more nurses, but that takes time. We can have more doctors, but that takes time. So, and then we talk about mid-level practitioners. You know, every nurse practitioner basically started out as a nurse, so you're filling one bucket by taking out of another bucket. So it's like you're not really solving the problem there. There's only one group of people that are currently sitting on the bench that can do absolutely nothing in healthcare, despite the fact that they have advanced medical training. And those are foreign medical graduates and doctors of medicine who did not match into the specialty of their choice. And now they graduate from medical school with a 4-year doctorate and quite a bit of actual practical medical experience. You can ask anybody that's gone to medical school for 4 years if they got good hands-on training taking care of patients, and they're going to say yes. Right now they can do nothing other than work at Starbucks. And so what we want to do is enlist them, get them in an environment where they're working under the supervision of a fully licensed doctor, and have them be an additional care provider. That really, really would help in rural healthcare settings, but also in a variety of healthcare settings. It'll help in rural hospitals. It'll help in family practice offices. It will help OB-GYNs. It will help a lot of people deliver a lot of more care, for the basic reason that there are thousands of these people every year graduating in Texas going to work at Starbucks instead of going to work in medicine, and they have got to get off the bench and be part of the solution.
Thank you.
David, can I add
Please.
something to that? So, we know from our friends at Torch, and John Henderson and his team do a wonderful job of, doing the Lord's work of keeping these hospitals open. And there's 158, I believe, the last count, rural hospitals, or what is classified as rural hospitals in Texas. Only 40% of those provide OB and baby delivery services at this point. And so you've got a situation where those hospitals are covering 12% of the state's population, but 85% of the state's geographic area. And so we have members. It might be more than 75 miles for them to get to a hospital. And so, there was an article I read last week in the Marshall News Messenger. I still keep up with my East Texas papers, but I believe it was Christy Francis, who's the board chair of Torch, and Dr. Emily Briggs, who's the president of the Academy of Family Physicians. And it was about rural health care. And one thing, Dr. Oliverson, that they said was an approach that needed to be taken to fix the situation in rural Texas on health care was, and I wrote it down, but improve health coverage options, which would reduce uncompensated care and strengthen viability, both for clinics, physicians, and hospitals. And so if you've got a toolbox, which you need a toolbox with many tools in it to fix this issue in rural Texas, one thing we see ourselves providing is choice. It's not for everybody, but it is a choice. More choice means more options, more compensated care, more compensated care. You've got an incentive to bring more people out, and hopefully that helps move the needle in the right direction we need it to go.
What a lot of people don't understand, as I said earlier, I've run hospitals. Can I admit a patient? Can I order a CT? Can I order labs on a patient? I can't do any of that. In fact, a mentor of mine very early in my career as a urologist, he said, David, nothing happens in a hospital except for at the tip of a doctor's pen. And in the big cities of Texas, we've seen a lot of them employ that pen. But we don't have a lot of those pens in rural Texas. And without it, it's difficult to accommodate the needs of the community that's there in proximity. So that's contributed to those closures, which has been very unfortunate and needs to change. But that's always a good lesson or something to keep in mind as we think about this. We need more medical professionals to be able to keep these doors open. We talked a little bit, I know tomorrow is transparency, but we started talking about, Torch has been fantastic and have enjoyed working with them. The one thing that irritates me on their behalf is that many of the big hospitals use them as a human shield to say, well, rural hospitals, you're going to hurt rural hospitals. I don't think they care as much about the rural hospitals, from my opinion. But it's important that we do focus on them first and foremost, but not ever at the expense of the patient. We've got to focus on how do we improve access, how do we improve affordability, having more professionals work there, having the ability for patients to know what they get to pay and have to pay up front. These are things that are critical for fixing the system. I almost said broken system. I hesitate to say that often because I think it works really well for a lot of folks. I don't know that it's been designed any way than the way it currently works. So it doesn't work for us. It doesn't work for the patient. So I think that it's time for the primary stakeholders in the healthcare system to take back their agency, to be empowered. And that's what many of the things that we're looking to accomplish and to have cross the finish line seek to do. Anything else come to mind, Dr. Oliverson, in terms of things that you're excited to look at and see? And I know you've got quite a few that you want to bring to the table.
Yeah, I mean, I think we always have to keep innovating, right? And I think we've talked about choice, we've talked about competition. I think these always have to be our driving factors. I think we have to understand the fact that there are healthcare resources out there in the community, but the traditional way that people have accessed them through an insurance product leads to overpricing, overutilization, incorrect utilization, and just generally a very inefficient, non-consumer-driven thing.
And if I may, the other choice, you mentioned choice, you've got the Association Health Plan, the MEWA bill that we're bringing back from prior session, which would, again, I'll let you talk about that, and then sure. I want to bring up your physician dispense.
Yeah, absolutely. Well, man, you got all my good stuff here. No, so MEWAs are basically multiple employer welfare agreements. So it's another sort of fraternal benefit plan. It's not technically considered an ACA compliant insurance product, like a big Blue Cross or whatever would be. But the basic way it works is this. So let's say I own an accounting practice and you own an accounting practice, and I've got 20 employees and you got 20 employees, and neither one of us can afford an insurance product together. And there's a couple other people in the room, and they've got accounting practices of similar size. And we're basically all essentially the same business model, same general types of employees, same kind of risk. We probably go to meetings together in Texas once a year with the Texan Association of Accountants, which is, I'm sure, a very exciting meeting. I don't know, maybe it is. But if we actually got together and created a health benefits plan that covered all of us, now we've quadrupled or quintupled or a factor of 10 or 20 or 50 or 100 or 1,000, multiplied that risk pool, which actually massively increases affordability. And so that's kind of what a MEWA does. And so what we want to do is expand the existing definition of MEWA. Right now, if you're a sole proprietor, you can't qualify to be in a MEWA. So you could have a MEWA that's set up for attorneys, and if you're part of a big, law firm, you can be in the MEWA. But if you're a solo practice attorney and it's just you and your wife and kids, you can't be in the MEWA, which makes absolutely no sense. So we want to clarify. That's kind of what we're working on. You mentioned physician dispense.
And if I could just add to what you just to dovetail on that, in many of these 5, 10, 15, 20 employed folks working for this firm currently go without insurance, or they go with, they're paid a stipend to go out and get their own. So it really would provide them with an option they never had before. And that's what it's trying to accomplish. It's trying to offer up a choice, trying to empower, and trying to put in place a tool that didn't exist there before for these guys, because now you've got an affordable option with richer benefits.
Mm-hmm. You mentioned physician dispensing. I think obviously that's another issue. Texas is one of, I think, 4 states, 5, 4. 4 in the United States that do not allow a physician to be able to dispense medications in their office for the purposes of giving, dangerous drug control. And by dangerous drug, I mean anything that's FDA regulated. I'm not talking about controlled substances here, but just hypertension medications, diuretics, diabetes medicines, asthma medicines, whatever. There is a growing movement that I'm very, very proud of and very excited about, because I think it has the potential to revolutionize healthcare by returning the power to the consumer, and that's what's called direct primary care. And that's essentially where, instead of basically a fee-for-service or an HMO type arrangement or PPO type arrangement, the doctor essentially receives a cash payment up front from a patient, and then the patient is essentially able to access that doctor for whatever and as many needs as they may have for the whole calendar year. And it works really, really well for a group of folks who find themselves uninsured because maybe they're a solo practitioner, maybe they're a small employer, maybe they own a convenience store or a donut shop or something like that, a small business, right? Small commercial retail type shop. They've got some resources, but they can't afford coverage, as we talk about it. And so this gives them the ability to access care on a cash basis, and these are actual real market prices. This is not some phony made-up number that gets negotiated behind closed doors between stakeholders that the patient never gets to talk to. This is an actual, doc, what's it going to cost for me to be in your panel? Well, it costs $1,000 a year, done, no problem, or whatever it is. Value-added services are key to the ability to deliver direct primary care at the most affordable way. And that's because if you're in direct primary care, you probably don't have full coverage insurance products. So you don't have a PBM, you don't have a formulary, you're not entitled to a discount. So you're paying full freight on your pharmaceuticals. It's whatever the price is that's out there in the market, which can be insanely ridiculous. You and I could have a whole other 3-hour panel on how PBMs have made pharmaceuticals unaffordable and not affordable, but that's neither here nor there. But direct primary care needs the ability for physicians to be able to dispense generic medications from chronic medical conditions for their patients enrolled in their panels, so that these consumers can get the maximum benefit. I mean, we're talking about, instead of going to the clinic, instead of going to the CVS and paying a copay of $30 and you're thinking, man, that's cheap. Well, what if your direct primary care gave you the same prescription at literally, and I'm not joking, like some of these prescriptions are like $1.82 for a 30-day supply? Because that's actually what it costs when you don't mark it up, right? So huge potential savings, and something that I hope we can get past this session. Lot of headwinds on stuff like that, but I you know,
Well,
keeping my
and
fingers
thank
crossed.
goodness for organizations like ScriptCo, which is a good Texas organization. Also, Mark Cuban's Cost Plus Drugs. I would say it was about 6 months ago, we were looking into a particular medication called Tecfidera that's used by multiple sclerosis patients. This isn't something they have an option of taking. If they are prescribed it, it's something they need to take. It's a generic drug. And by the way, this was, the bill is non-scheduled drugs.
That's right, not scheduled drugs. And also, just to be clear, this is not about making money for doctors' offices,
cash.
right? So we actually specified in the bill language that there can be zero markup on these drugs. We don't, this is not about somebody having a pill mill and making a pile of money. This is about, I'm already in your practice, I'm already paying you a fair amount of money for this, and you want to be able to give me my prescription drugs at basically the exact price that you paid without any markup. That's what we're trying to do.
Cover an overhead. But it's, so getting back to this medication I'm telling you about for multiple sclerosis patients, the retail, generic, the retail value, if you looked at GoodRx, between $700 and $900 a month. If you went to Cost Plus Drugs or ScriptCo, any guesses? $700 to $900 retail, $27. That's life-changing money for people that have a chronic disease. I also want to tell a story that will drive this home for how silly the restriction for the restriction for physicians to sell medications at the point of care. Mind you, they give them away anyway in samples. But let me just tell you a quick story. I had to take Maisie to take care of an issue for her allergies. And they were just getting bad, having difficulty breathing. And so we went in. The doctor said, it's just a bad inflammation. We're going to get her some medication. Go to the front desk, and they were able to sell me the medication right there at the front desk. How was I able to do that here in Texas? Maisie's my boxer. This was the veterinarian. A veterinarian can sell medication for your dog, but a medical doctor cannot sell you medication that you need at the point of care. We just need to stop with the silliness and do what's right for patients. How are we doing on time? I think we're about ready for, yeah, 7 more. I think are you guys open? Good with the opening for Q&A?
Questions. Yes.
We're only going to take nice questions.
No, we take all questions.
No, we take all questions. But the only thing I will ask is that please make your statement in the form of a question. We want to take advantage of the folks here on stage and tap into their knowledge base and be able to have them address something that is a question. So please put a question mark at the end of your statement. Yes, sir. Well, we got mics coming around as well. Please remember we're running live on our live stream, so we want to make sure the audience hears what everybody has to say.
Within the legislative initiative, is it possible for all these various groups serving the rural communities to have an initiative sponsored by the state to where the number of groups, medical, all these different groups could represent a significant number of people in order to have a across-the-board initiative advancing rural prosperity? Because obviously Texas, without its rural character, it's not going to be Texas anymore. And with the increase of job access, people can live in rural communities nowadays, you could factor that in. And I just wonder, would the legislative process allow for a group that advocates strictly for rural Texas?
Yes, and I think that's already happening. And so, I mean, it is one of those things that you do see when we passed the Farm Bureau health plan bill last session. It was a coalition of mostly rural folks. It was rural members that were helping me with this because they saw the value. Chairman Frank, Doc Anderson from Waco, which is, it's not super rural, but it's kind of rural. It's less rural than it was now that we have the silos there, but it's still sort of rural, right? Right. All right. So anyway, I do think that happens, and I do think that, to your point, though, there's a disconnect. It's very easy for those of us who are in large urban areas where a majority of healthcare services are concentrated to sort of think of anything outside of our bubble as sort of beyond the walled city of the dystopian future, and it's all wasteland out there, right? And that's a bad way of thinking. So we have been very blessed to have groups come. You mentioned Torch. We've had doctors come. We've had nurses come. We've had patient groups come. We've had a variety of chambers of commerce come and just really impress upon us, like, we're kind of at a breaking point here. Like, rural hospitals are closing left and right, or they're being snatched up. We didn't even talk about the demon of consolidation. But, that's a whole other issue right there. So, yes, I agree with what you're saying, and I think that obviously that is important. The larger that voice and the more unified it is, the harder it is for folks to ignore.
Do we have a mic?
Yep. Sir?
Has the governor's office identified the 15 key issues of a healthy rural Texas and have made it a priority out of that office? To me, everyone's going to have to be on the same page with regard to all the things that have to be done, because any number of these one things that doesn't get accomplished could be the thing that would cause a town not to prosper. And I'm just wondering, we've got a lot of talent. I just wonder if all of these markets together would work to determine what these 15 or 16 or 20 issues that have to be addressed in order to have a prosperous rural Texas.
Well, and you were right about healthcare being one of them, because if we're going to see growth in cities outside of Austin, Dallas, Houston, and San Antonio, there needs to be robust healthcare. When employers are looking to come to Texas, they're looking at education, they're looking at taxes, they're looking at a number of things, but healthcare is one of them. So it's something that needs to be built upon in a significant way, especially in secondary and tertiary markets here in the state. We had another question?
Yeah, a couple of ones. One is, it strikes me as that rural communities, since they've had to do with so little resources in so many different areas, is really a great breeding ground for new and innovative ideas in healthcare, like direct primary care, which is what I do. And thank you for mentioning direct dispense. Good luck and Godspeed. But for immediate things, one is a young lady asked a question too, is can higher education, besides the long training pipeline, is there something they can do immediately? And then kind of right along with that, during COVID, so many bad rules were put in place that harmed just the healthcare professionals, kicking people out who had COVID, wouldn't get a vaccine shot and so forth. Are there things that the state legislature can do to actually undo some of the dumb rules that were put in place and find other ways to get immediate professional support out there? Thanks, guys. Non-hostile question.
I like that question, actually. I think that's good. And I think that every good conservative lawmaker, that's one of their prime directives, is to find dumb, unnecessary governmental rules and abolish them. And so, yes, we are always on the lookout for those things. And I have sunsetted happily my fair share of them in the insurance industry, which is kind of my area of expertise, and do it with extreme prejudice. So it's an ongoing quest. You mentioned pipelines as far as healthcare, and I think these are innovative strategies that need to be embraced. There have been successful pilots and successful things both here and in other states that have looked at either free or reduced cost tuition for healthcare professionals that are willing to train in a rural part of the state, with the idea that if we tie you down there for 4 to 8 years and you start having connections to that community, you might just grow to love it and you stay there. And I think that is one of the biggest struggles that rural communities have in the healthcare space, is the allure of money in the big city, right? And so you got to get people to put down roots. That's the only antidote to more money is, well, but my family's here. My kids go to school. Their soccer friends or baseball friends or whatever, you know, are here. And, you know, my wife, you know, she works here in the school district, and, you know, this is where we want to be, you know. So, I mean, I think that's an innovative strategy that we need to continue to look for ways to expand training in rural communities with the idea that it ties people to those communities and then they don't want to leave.
In addition to the consolidation question that we didn't address, I think another one that you caused me to think about, and it might be the opposite or the other side of the coin of what you discussed, something that came about because of COVID that wasn't as prevalent, that is now, and that may be something that's good depending on how it's implemented, is telemedicine. And that was another one of the priorities in our last legislation. I don't know, I have not seen anything in this coming session, but I know that there's been a lot of progress, and I don't know if this is also something that the Farm Bureau has been implementing as part of what you all are doing, but it's been encouraging for me to see more people using it, and not just for telemedicine, but also teletherapy.
Yeah, so we do offer teledoc on all the products we offer, and you know, that's something valuable to our members. As far as the broader field of telemedicine, how far it goes, you know, I'm basing this on anecdotal experience, but so I could be off the mark if there's any academic study out there contradicting me. But it seems to me the impact it's had on my family in rural areas and the way they use it, and how great it's been for them, that the usage in the rural areas has helped pull telemedicine along, make it more than what it was just a few years ago. You know, my folks still live in Carthage. There's only a handful of physicians there. If their physician is out of town that week or at the hospital and they need to see him, you can't get an appointment. So telemedicine really is a valuable tool. It's something we wanted to make sure our members had access to. And, you know, with the rural broadband continuing to be deployed, it'll be interesting to see where this goes.
Yeah, I mean, I agree. I think I mean, those of us that work in the profession know, like, I don't think, at least I hope, teleanesthesia is never going to be a thing. I think you actually want somebody physically in the room when you're unconscious and your vital signs are being supported by a machine. You don't want to know that somebody's just sort of pushing buttons remotely, and hopefully you make it. You know, same thing with delivering babies, same thing with doing surgery. I mean, obviously we have robotic surgery, but I mean, there's just certain things that, you know, one of the great physicians of the 20th century, William Osler, often said that you know, tests are great, and, you know, radiology can tell you some stuff, but the reality is if you could put your hands on the patient and do a good physical exam, you can get all the information you need without ever ordering a test. So I don't think there's ever going to be a substitute for a face-to-face consultation and the ability to examine a patient, and I think we have to be cautious about the limitations of telehealth. We don't want to, as I said, turn this into sort of a dystopian Sigourney Weaver Aliens, you know, the doctors basically the machine you lie down in, and, you know, it's just a bunch of needles stuck in you and stuff like that, whatever. I mean, I think there's an important human part of healthcare and care delivery beyond just the physical exam, too, that's important. But I think it's a very useful adjunct to filling some gaps where we may not have this specialist or that specialist in a rural area to be able to consult.
We have another question.
Dr. Oliverson, you mentioned the lack of insurance providers in a number of counties here in Texas. In the last 5 or 6 years, we've had, I think, 17 states implement some kind of reinsurance or some risk mitigation strategy via a 1332 state innovation waiver. Georgia, in particular, within a month of them announcing that they would have a risk mitigation strategy, they doubled the number of insurance providers in the state. And after they implemented it, what they figured out was that some of their rural counties who just had one provider or who had been a bare county prior to that, those providers were more open to, they started doing business, they broadened their footprint. Would Texas be open to doing something like that? Has that been discussed?
So let me just say that I personally believe the solution to our problem of inadequate coverage is always more options. You've heard, I think, everybody on this panel say that one size does not ever fit all. government-controlled healthcare is the wrong way to go. Now, I will say, interestingly enough, if you do in some statistics, you will find that Texas has the second highest number of ACA enrollees of any state in the union, succeeded only by the state of Florida that has 400,000 more than we do. We're sitting at 2.4 million, they're sitting at 2.8 million, which blew me away because I thought it was going to be California, New York, and all this kind of stuff and blah, blah, blah. But it's not. It's actually us. So that tells you there's a lot of individuals out there, a lot of Texans that depend on the exchange to provide health care. And I'm framing the answer this way because you mentioned 1332. What the Biden administration is doing right now is doing everything in their power to use the ACA to enforce single-payer health. We're seeing that because they control the exchange at the federal level and they get to write the rules for participation, they've done everything humanly possible to narrow competition, restrict choice, and make everybody fit their square peg into a round hole when it comes to coverage options. They are eliminating choice, they are eliminating competition, and they are moving towards single payer. The silver bullet is that states like Georgia have figured out that if you take control and you do your own exchange, you can still have all the benefits, but now you get to write the rules as a state as to how much competition, how much innovation, how much choice, how much consumer-directed spending do you want to allow. You control your own destiny. Part of that, obviously, is the idea of having a risk pool, which is something that needs to be explored. But one of the other things that I think we're working very carefully on is the ability to provide basically a subsidy or a savings, if you will, for employees of small employers that can't afford group coverage. They have 10 employees. We talked about MIWAs. There are employers out there that are never going to be able to buy group health or self-insure because it's A, unaffordable, and B, they don't have enough people in the pool. That doesn't mean they just want to make their employees uninsured. They have some dollars they could put towards the problem, but they don't have enough. So if we could have a system where we allowed innovation, we allowed competition, we allowed these insurance products to be sold in Texas in ways that were innovative, that used 21st century technology, handheld devices. You mentioned telehealth, the ability to video conference and be able to get some questions answered and sort of take care of a variety of things. All of these innovations exist, but the federal government is squelching them out of healthcare.gov. So that's why Georgia's doing what they're doing. This is actually the second time they've told the federal government they want to do an exchange. Their waiver got rejected last time, as I recall, because the Democrats in Washington said it looks too conservative. And so they were like, to heck with you, we're doing it anyway, and we're filing again. And so, I feel like they're going to make it this time. And so this is obviously something that we need to do. Doesn't matter where you live in Texas. If you were able to access an exchange that was Texas-owned, Texas-driven, Texas-specific, you could that would be one possible tool in the toolbox for you. So I think all strategies are on the table.
Do you think that's a bill somebody might file?
I think it might have already been filed, but yes.
All right, any other questions?
Question. The provisional licensure for the unmatched grads, will that be time limited, or is this something they can do for 15, 20 years, or is there going to be a pathway to help them bridge back into the match? Because as it states in here, the longer they're out, the harder it is to come back and match. So what's the long-term
It's
plan
totally
with
up
that?
to them. That's a good question. Totally up to them. I will say that it doesn't envision a graduation to a full medical licensure without doing a residency and being board certified as a normal training pathway. But I think you have to consider the fact that one size doesn't fit all in career pathways. And you and I both know people that started out going to medical school and ended up deciding that they just wanted to be a physician assistant or an anesthesia assistant or some other kind of thing because they just said, you know what, the return on investment is just not there for me. I've got a family now. I've got other responsibilities. I'm not going to do 80-hour work weeks, or more, and it's just not going to work for me. So I think that if people like that, and I want to say that, to be clear, when we talk about unmatched people, the match is a horrible process. It's literally like the worst nightmare you can have about being in 7th grade and not picked to play on the flag football team or being the last kid to get picked. It's worse than that, because you go out and you interview for all these places, and the school builds you up to think you're going to be a neurosurgeon someday. And you go out and you apply to all these places, and then you open the envelope on match day, and there's a big fat goose egg, and you got nothing. And now you've just spent the last 4 years of medical school moving towards a career that you probably have a 0% chance of ever doing for the rest of your life. And you have less than 24 hours to figure out what you want to do with the rest of your life. And by the way, you're fighting for the scraps along with everybody else who didn't match. So you may have been one of the smartest, most competitive people in your class, but you're in the top 20%, not in the top 5%. So you're not doing dermatology because you were just sort of fell outside the thing. And there's no place for you to go. The best you're going to get is a 1-year transitional internship where you get treated like a slave, literally, for 12 months, and then at the end you're cut loose and you got nothing. And so this is a different way to go, and this is going to work for some people. And it's just, and it's fair, and it gives people the opportunity to make some money and pay back some student loans instead of working in a coffee shop or jumping into a field that they've got no knowledge of whether they're actually going to like, and just pray it all works out. It gives them another option. I fully expect there will be people that will never go back to residency. And you know what? That's fine. It's their life. Let them do what they want to do with it. And there will be others that will go into whatever, something different. You know, maybe they were thinking they were going to be a thoracic surgeon, and now they're find themselves working for an OB-GYN, and they say, you know what, I like this. I want to go back and I want to try the match again, but this time I want to do OB-GYN. I don't want to do thoracic surgery. And they match. Great. Perfect. But the idea that somehow you're going to figure that out in the 6 hours between the time you find out you didn't match and the time when it's all over is pure insanity.
Any other questions?
Thank you so much. My question is in regards to the timeline and the obvious extended timeline for physicians to get to these rural areas. I know there's been a talk of increase in GME funding this year. Is there any more efforts towards increasing funding for repayment for loan programs specifically to rural areas?
As far as I know, the answer is yes. However, I'm going to provide a disclaimer caveat, and that is that I am not an appropriator, and I never have been an appropriator, and so you're asking the wrong guy about how the budget works.
Saw Dr. Porter's hand go up.
Really quick on, so residency programs are funded by Medicare throughout the states. Can Texas actually open residency programs for some of these? Although I really do actually like the idea of the assistant physician program as well, but I don't know if we can actually fund that ourselves practically here.
I'm not an expert on this, again, but my understanding is that some of these residency positions for some of the new medical schools that have opened recently are privately funded. And so I don't think that they're all exclusively through CMS. I think Sam Houston State in particular, which has a DO program focused on rural primary care opportunities, many of their postgraduate training positions are privately funded by community hospitals and philanthropy and folks that are like, yeah, we love to have a resident out here where we are because our hospital is barely hanging in there, and this would be a blessing to us if we could get another doctor to start taking call here.
And I think the University of Houston has a residency program that was funded by the Cullen Foundation. I could be wrong about that, but I think that's right. Yes, sir.
Hi, I'm Noah, and I'm a Sumner Scholar from Shrine University, cell bio major applying to medical school this coming summer. So thank you for the reality check on residency matching. But
statistically, you'll be fine, Noah, don't worry.
I appreciate it. I also work as an EMT, and I've been doing that since high school. And I work for City Ambulance Service just because time scheduling is more flexible with school. And we have trucks and stations, and we cover areas all across Texas except the valley. And whenever I ask why we don't have coverage in the Valley, it's because, well, we're not going to get paid for it, right? The company isn't. And earlier, it was mentioned that competition leads to a reduction in, uncompensated care. But in my anecdotal experience and my discussions with people, it seems like it's the opposite. It's because there's uncompensated care, there's no competition. So instead, my company, my truck will get sent out from San Antonio all the way to Brownsville to transport someone back to San Antonio because there's no care down there, there's no ambulances down there. And the partner that I'm working with lives in Brownsville and doesn't have a place to work for in Brownsville, and so came all the way up to San Antonio for his shift. And so do you have any more explanation as to how we can add competition, and stop that cycle of, competition and uncompensated care?
I actually think you should go into public policy. You've just diagnosed one of the biggest Achilles heel problems that we sort of have that's in this country in healthcare, and that is that you do have the bucket of the have-nots, right? And a lot of that is an affordability problem. It's not an access problem. It's not that we don't have providers that would see them. It's not that there's not options available for coverage where they live or care where they live. It's that it's unaffordable for a variety of reasons. Part of that is what we've talked about here today, is that when it's not just providers, but it's opportunities to get access to health care through some sort of a payment arrangement that works for you. There's a lot of places where there's just not competition, and that's problematic. And because, as you point out, I think very correctly, when providers provide service, they deserve to be paid. Whether you're an anesthesiologist, working in a trauma hospital and the hospital's getting a big chunk of money and you're getting nothing for donating your time to the care of an uncompensated care patient, or whether you're a doctor practicing in rural Texas and somebody, comes into the clinic and they need help and you're there and you're the only person there, and the Hippocratic Oath, you're going to take care of them. And it's like, there's, here's a bushel of fruits and vegetables maybe, or nothing, right? I mean, that's not what we envision for healthcare. So I think big short answer to your question is that the only way to unwind that problem is to make sure that Texas continues to look for innovative solutions that reach into that uninsured population, the truly uninsured population, and give them options for healthcare financing, I guess is probably the best way to refer to it, that's affordable for them, that meets them where they live. And that may be insurance, that may be sharing, that may be Farm Bureau, that may be direct primary care, that may be HRA, HSA, high deductible plan, that may be BWAS, that may be stuff that we haven't even thought about yet. But that's the only way to unwind that problem, Noah, is to put everybody in a position to be able to afford care when they need it. You bet.
We're down to 2 minutes, and I just want to use these last 2 minutes to talk about another issue down in the border. The workforce shortage that we have is being exacerbated by our own federal government. In talking to a number of folks that are in Del Rio and Harlingen and Eagle Pass and El Paso, at the camps that are along that border, they have a mandate for hiring certain medical professionals, and they are paying 2, 3, 4, 5 times market rates to recruit these people away. So our hospitals in Del Rio is the most recent story I heard from folks down there. They don't have enough people. They don't have enough nurses. They don't have enough doctors. They don't have enough EMTs. The EMTs, they had 3 trucks, and they lost 2 of their EMTs to one of those camps set up by HHS, because the gentleman I spoke with is getting paid 3 times, and I can't fault him for that. So we have this issue that is being exacerbated and made more problematic by our own federal government, which is something that needs to be changed and possibly even looked at here, so that we can accommodate the needs of those small towns that don't have the care that they need normally in a sufficient manner. But it's just getting worse and worse. So it's a particularly interesting and terrible problem that needs more and more attention. I appreciate you bringing that up. I have just one thing to say. Please join us for our next panel, moderated by the Honorable Larry Taylor. The panel will be in the Zlotnick Ballroom at 3:15, followed by our complimentary cocktail reception at 4:30. So I hope that you can continue to join us. Gentlemen, thank you for being here today. You did a great job.
Pleasure.
Thank you.
Hey, and y'all give a special round of applause for David Balat. TPPF actually leads the nation on conservative healthcare policy initiatives, thanks to David. And everybody's watching what we're doing, thanks to David. So y'all are very blessed to have him here.
And I'm very happy to have you guys be in the room, because otherwise it'd be empty. So thank you for being here. Thank you for your questions. And if you have any questions, we'll be around here for just a few moments.